Hi, good evening. Hello.
Hello, sir.
Hello, good evening.
Good
I'm the
evening,
first
sir.
one to join, right?
Yes, sir.
Okay, okay. I think there are only three panelists, so they will join leisurely. I'll try to do my screen share.
Okay, sir.
Okay.
Yes, it's perfectly coming. Yes, sir.
Okay, okay, fine. So yeah, you
Yes,
could
sir.
download the presentation that I sent by
No,
email.
sir. I need to check it, sir.
Okay, okay. Please check it out.
Sir, can you please send me once again in my official mail, sir? I hope you
Your
sent to
mail?
Miss Ritu Safar.
No, 1 second. I've sent to rituparna.bhattacharya@clinic.com.
Okay, this I'm refreshing my mailbox once again, ma'am. Sir,
Okay, okay.
thank you. So, do I need to share the PPT, sir?
Yes, yes. That's a video file. Just download and play the video in case the third speaker is not joining.
Okay, got it, sir.
Okay.
Right. Thank you.
Just let me know once you download.
Sorry, sir. Can you please come once again?
Yeah, in case the third speaker is not joining, you need to
Then
share the video.
Okay, sir. Okay.
Okay.
Good evening.
Good evening. Good evening. How are you?
I'm good. We
Good.
still have a little time, right? It's only
Yeah,
6.
yeah. Yes, yes. Only 6:40 now.
Yeah.
So,
You will be projecting the questions, Dr. Sanish?
yes.
Yeah. And
I'll
we'll
read it
discuss
out.
the answers at the end after all the
Yeah.
presentations are finished.
Yes.
Right.
Yeah.
Right. Fine.
Okay. Mhm. Dr. Binny, good evening.
Yes, good evening, sir. Good evening.
Good evening. So I'll do the questions today.
Okay.
Okay.
Ma'am is, Acha, okay, ma'am is, Ranju ma'am will be answering them in the end. ठीक है.
Yes. Yeah. Hello, good evening, Dr. Kumar. Hello, good evening, Dr. Kumar. Can you hear us? I'm Dr. Sanish. Hello.
Hello, am I audible, sir?
Yeah. Now you're audible.
Okay.
Can you come a bit closer to the webcam? Because only, yeah. Okay, fine. Shall we do screen share from your side?
Yeah. I'll put it in screen share mode, slideshow mode.
Slideshow mode, please.
Yes. Good evening, ma'am. Good evening, Ranju ma'am.
Good evening, Vineet. कैसे हो बेटा?
मैं बिल्कुल ठीक हूँ, ma'am.
Good. एक बार मेरा भी स्क्रीन शेयर चेक कर लेंगे once she's
Yes,
finished. Just
yes.
go through it once.
Dr. Kumar, yeah, fine. Right now it's fine.
Okay.
Can you move the slide forward, please? Yeah, fine. Perfect. Okay. You can stop screen share now.
Okay.
Shall I share and
Yes,
check?
please. Yes,
Yeah.
yes.
You can see it?
Yes,
Slideshow
ma'am.
mode, please.
Slideshow mode,
Yeah.
ma'am.
Just a minute. Yes.
Yes,
Yes, ma'am.
fine.
Fine.
Okay, visible?
Yes,
Visible,
ma'am.
visible.
Okay, fine.
Actually, I was thinking our pre-test questions, no?
Right.
Our pre-test questions, the options are very like I don't know how we'll give them time because it's like immediate acting and intermediate release and immediate release and all. Technically, right now I'll read out the questions options and finish because they won't see the screen again.
Okay.
So how they'll answer, that is my query. Like this is a practical issue.
What we can do is we can just see the other option is to do it in the course of the study. I mean, in the course of the webinar. The other thing is we can just project it leave it 7 seconds on, and then re-project it at the end. That can be done, and then they can see. They have to actually do it in the chat box. There is no other way.
Yes,
So
yes,
we have
yeah.
a separate link, and they have a separate link. So
Yes,
how do
yes.
we know what they have answered?
No, right now we don't have a mechanism because there is going to be a delay also, 15-20 seconds delay. So
Yes.
there is no point waiting for them to answer. We assume
Okay.
that they answered something in the text. We'll go ahead with the answers. But I
Okay.
am thinking about the practical things like this is
Yeah.
the first time we are doing 4
Yes.
questions, four options, 16 options. They are very unlikely. Otherwise, they should be ready with pen and paper to note down.
Yes.
So
So
probably I'm thinking about some QR code to be presented along with the presenter's slide or something. I don't know. This is an experiment. We'll see how it works.
it usually works out when there is a same link for the delegates and for the faculty. So the delegates can do it in the chat box and you can see it simultaneously. Now, I don't know whether this is possible with separate links or not. I'm not very sure.
And otherwise, I think is along with the flyer through QR code, we can share it.
Yes, maybe.
So they can see at any time.
Okay.
So we'll think about that, something like that.
Good evening, sir.
Radhakrishnan sir, good evening.
Radhakrishnan sir, good evening.
So, how are you?
I'm fine, sir. How are you?
Good, good. I'm okay. I'm okay. How you all are?
Good evening.
Absolutely fine.
Fine, sir.
Everybody
Good
is
evening,
absolutely
sir.
fine.
All fully prepared for Diwali tomorrow.
Good, good, good. Diwali is
Okay.
tomorrow or day after?
Sir, tomorrow.
Tomorrow.
We'll hear lots of firecracker sounds in between the webinar also, don't worry.
Yeah, don't worry.
Kids are
That's a
getting
welcome.
bursted
That's a
outside.
welcome. Good.
The kids are bursting crackers.
Yeah, crackers.
In spite of
Have a
everything.
temple nearby. There are also some crackers and some sort of loudspeaker.
But in Delhi, sir, there is a complete ban on crackers. On the buying, the production, the sale, even online sale, there's a complete ban this time.
That is everywhere, not in Delhi alone, everywhere. Something like in the
But this
northern
time it
part of
was very
Kerala,
late.
some people died yesterday. There was a massive leak because something, well, they were playing with the crackers. Children were playing with the crackers. But unfortunately, it went to the store where all these things are stored. And nearly 7 people are dead. Nearly 100 people are already in the hospital in Kerala.
I think last year also there was some mishap in the factory that manufactured crackers.
A mishap in the factory, correct?
Yes, and many child
Really
labor
not a
children
mishap.
were also there.
Yeah. Somehow children were playing with these small crackers. Somehow one went in to the store place where everything was there. And well, people enjoyed a good show.
I'll also ring up Dr. Nitin and find out how he's placed, Dr. Sanish.
Okay.
Just
Fine,
give me a
fine.
minute. Yeah.
Rituparna, any update on the successful download of the video? Darshan sir, I was going through the pre-test questions.
Yeah, I saw that.
Yeah,
You are
so
reading that.
practical issue is like they won't be prepared for the questions and answers. Even if you are giving 2 or 3 questions,
Yeah.
so they are not seeing it continuously. Once we read the questions and options, it vanishes. So maybe from next time we can have some other mechanism, like through our webinar flyers or something. 1 or 2 days prior, we need to announce the questions.
Sir, sorry for interrupting, but can we go
Okay.
live now?
Yeah, how about that video download? You got it?
Yes, sir.
It's successful. Okay. So
Okay.
in case the third speaker is not coming, you can proceed to
Okay.
project it. Okay,
Oh, okay, sir. Okay, sir.
fine. We can go live now.
So shall I start my screen sharing?
No need.
Okay.
Because after the welcome address, there is a special address by Dr. Sood. Then we'll have the pre-test and then only your lecture will start.
Nitin is, I think, unable to take the call, which means that he might be still with the
Okay.
VIP. So
Okay,
we'll
fine.
just download his video and show
Yeah,
it.
it's
Right.
downloaded and it's
Right.
with Rituparna. So she'll play it for us.
Right,
Hmm?
right. Thank you.
So, okay.
We have a coordinator today. Hi.
Good evening.
Hello, Jayashree.
Good evening. All good.
Hello.
Good evening,
Good evening, ma'am.
Sanish.
Good evening.
Ranju, has she joined?
Yes, ma'am.
Yes.
Okay. I'm the later. I'm the late one.
Ma'am, shall I quickly show the slides so that?
Yes, please.
One second.
First of all, Diwali, I believe.
Yes.
Good.
Okay.
It's the first one.
Right.
Okay.
Uh-huh. Yes. That's fine.
Then
Great.
Dr. Ranju's CV slide is
Ranju,
also there.
absolutely.
Okay.
Lovely.
Fine.
Thank you. Hi, Ranju.
Ma'am
Anyway,
is,
that's okay. Vineet, okay.
yes, good evening, ma'am.
Good evening.
Good evening, ma'am.
Hello, how are you?
I'm good, ma'am. Dr.
All-
Upma.
I know you. So well. How nice.
Happy Diwali, ma'am.
Happy Diwali to all of you. Happy Diwali, happy Choti Diwali today, and happy
Today is-
Diwali tomorrow.
And we'll hear loud cracker sounds in between the webinar.
Wonderful. Joy.
Good evening, ma'am.
Hi, Ranju, how are you?
I'm good, ma'am. आप कैसे हो?
All good. मैंने कहा रंजू तो बड़ी तैयार क्यों रुके, मैं भी थोड़ा सा कर लूं. नहीं तो I was in my, you know.
मैम दिवाली है तो तैयार तो होना ही चाहिए ना.
Ideally होना चाहिए, I know. That's right. That's right. All good.
हाँ जी मैम,
Lovely.
absolutely.
Great. Great. कुछ फ्री होए कि नहीं, कि अभी भी बिजी इन समथिंग एल्स?
सब्जी बैग, बल्कि मैम हमारा जो थर्ड स्पीकर है डॉक्टर नितिन, वो पीएम साहब के साथ टूर पे गया हुआ है. पीएम साहब दिवाली पे जाते हैं ना कहीं बॉर्डर एरियाज में.
हाँ 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 हाँ.
तो उसको कल सुबह इंफॉर्मेशन मिली दैट उसको टूर पे जाना है.
ओके.
वहां तो मना भी नहीं कर सकते हैं. तो
हाँ.
फिर देन वी मेड हिम रिकॉर्ड हिज लेक्चर इन द नाइट येस्टरडे. आई सेड आप
Okay.
रिकॉर्ड करके दे जाओ, हम लोग प्ले कर देंगे.
Okay.
Because
So,
he may be at an area where neither
नहीं,
laptop is
you did the
available
right
nor
thing. You
connection
did
is
the
available.
absolutely. बिल्कुल ठीक किया तुमने.
तो हमने
Yeah.
रिकॉर्ड करवा के रख लिया था मैम. अब
Yeah.
he shared it in the
Right.
morning.
Right. हाँ, बहुत अच्छा किया. And Sanish, those pre-test questions that you were saying.
Yes. Yeah. So today we'll read out 4 single best answer MCQs, and towards the end, Dr. Ranju will explain the answers.
Okay. And when will these MCQs be announced? The questions?
No, after the introduction of the theme, Dr. Ranju will ask
Okay.
me to present the pre-test questions.
Okay,
After that, the
fine.
first lecture starts.
Fine.
After all 3 lectures, answers will be explained. Then we'll
That I
take the
understand.
audience questions.
ठीक है. Lovely.
But I think still we have to work out on some other way, because audience, they may not be joining in the beginning and they don't get the questions and answers continuously. So we need to find out some other mechanisms.
हाँ.
Because
Because
once the
उनका
slide
लिंक
disappears,
फर्क होता है ना मैम, तो हम लोग उनको चैट बॉक्स में उनसे we can't
हाँ.
communicate with them.
हाँ.
और करना पड़ेगा इसके लिए.
I think,
mean, this
so, ma'am,
is-
your suggestion was better that the speaker maybe poses the relevant questions as per his talk in the pre-test, and at the end, they can be submitted.
Yeah.
Maybe.
Yeah. So
And
you
we can
mean
show
जैसे
the
first?
slides of the questions after every lecture.
that will consume time. Because 4 questions with 4 responses, that itself will take 3 to 5 minutes.
Definitely that issue will be there.
That is there.
But maybe we can just flash and the speaker can
just
just speak
flash
about
every
the
time,
question pertinent to his or her distributed topic. And at the end, one person can summarize maybe in 2 minutes for the total this thing. Maybe that can be worked out.
No, next time maybe we can have the question answers at the end of the relevant talk. I mean, get the talk done, then get 2 questions displayed, and then the next talk and the next
Yeah.
questions. Maybe
Okay.
हाँ.
Yeah, let
that
us.
way it will make more sense to them also.
Yeah.
Because if the questions are related to the talk, then they can answer it better after they've listened to the talk.
Good idea. So we'll
And
see.
then at the end, we can flash the answers at the end.
Yeah. So today, Sanish, you want it before Ranju should give the questions before the talk? We still
Yeah,
do that?
we'll try it out. Today we'll do like that.
ठीक है.
Next session we'll try to modify. Maybe in another
Fine.
few
आज
sessions we can
try करके
stabilize it.
देखते हैं ऐसे.
ठीक है.
Okay.
Right.
The way we decided today, and after that we'll decide what should be the future way.
Yeah.
What should be,
Abs-
so if there is any modification required, we'll do it in next time.
Absolutely.
Yeah.
It's 58. Shall we
Yeah.
start with the countdown video?
I think so.
We can.
Yes,
We can
yes,
go ahead.
absolutely.
Okay, sir.
Ritu
Got
can
it.
start.
Yes,
Yeah.
sir. We are playing the video.
Is-
So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the Indian College of Anesthesiologists, and the focus of today's session is pregnancy-induced hypertension. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. B. Radhakrishnan, sir, the Honorable Academic Chairperson, to start the event today with his enlightening words and for further coordination. So, the time is all yours, sir. Please proceed.
Thank you, Ritu. Good evening, everybody, and welcome all to the webinar of Indian College of Anesthesiologists. Indian College of Anesthesiologists is growing well, and more laurels are being added to our credits. And our webinar, with certain changes, what is needed for the time, is in the 4th year of delivery. And the webinars will have some other change and will be more academic than what is being said today. And it may have some international touch also very soon. Today, the webinar is going to be on pregnancy-induced hypertension. And the webinar is going to be moderated by Dr. Ranju Singh, who is a professor, director, and head of the department at Lady Harding. And she is ably assisted by Professor
Upma.
Bhatia
Dr.
and Dr. Vineet. And from today onwards, we are making a slight modification of the program through a questionnaire. We're going to put some model pretest. The answer will be delivered to you later at the end of the sessions. And the programs for the coming months are also complete. Well, we may be able to put it on our website very soon for your reference. Today, before we start the program, I request President Jayashree Sood to come out and give a glimpse of what she witnessed with AISA conference, which was recently concluded, or rather being concluded now. Well, you all know, we are somewhat well associated with the American Society of Anesthesiologists, and 2 or 3 members from ICA goes every year since last 5 years. And we used to have some organizational meetings or say business meetings with ASA. And we are allowed to participate in every particular program of the ASA. And the relation with ASA is growing stronger and stronger. We are thankful to our international dean, Dr. Kumar Bilani, who is organizing our link with ASA. And I request Dr. Jayashree to tell something about or the highlights of the conference, as well as if you have some images of the show, what was going on there, which you witnessed, to be shown to all of us. Over to you, Dr. Jayashree.
Thank you, Dr. Radhakrishnan. Good evening, everybody, and wish you all a very happy Choti Diwali, as we call in Delhi, and Diwali tomorrow. And it is such an auspicious day today, and we are holding our 224th webinar, which is really very, very special on this special day. So as Dr. Radhakrishnan said, to just give a glimpse of the anesthesiology annual meeting, which was held in Philadelphia from 18 to 22nd October. Of course, the choices and the all the members were asked if they would be wanting to go to this conference, because we are very lucky that with the ASA liaison, they have allowed a sort of a modified or a reduced registration for the candidates who are ICA members. So we did have three of us who went: Dr. Angelina, Dr. L.D. Mishra, myself, and later on Dr. Aruna from Chennai also joined us. She is also a very active ICA member. So, of course, this was the welcome, which I thought you should all see. This is the huge convention center at Philadelphia, and there were a whole lot of halls, as you can understand, like we have, but these halls are all jam-packed. The session starts at 7 o'clock or even earlier sometimes, and all halls are full. So this was when Angelina and myself had just come on the 18th of October. Then, of course, they were as Dr. Radhakrishnan said, that we have had liaison with the ASA, and Dr. Angelina and myself were lucky, fortunate that this time we were given 2 lectures. Angelina spoke on labor pain and labor pain practices and media practices, and I was given a talk on the global burden of cancer. So both the sessions were very well appreciated, and surely it's a big thanks to Dr. Bilani, our international dean, who you can see there. Now, we had several meetings. So we had a meeting with the ASA leaderships, and here you can see the present president of the ASA, who of course has now given the over to the next one. So both the presidents are here. Dr. Bilani is there, Dr. Mishra, and Dr. Aruna and Angelina, you can see. So this was a very fruitful meeting in which, of course, many suggestions were made from our side, and they were very receptive for it. So I'm very hopeful and very optimistic that if we all work as a team, we can take this association forward with them. And we also asked something for our students, so that the ones who probably are involved in research, if they can be given an opportunity to present there. So this was a very fruitful meeting. We also met the leaders of the APSF, as you can see here. He's the president, and Dr. Elizabeth, she's the vice president, and they were also very receptive, and they actually were very keen to know how we want to promote patient safety in our hospital, in our country. We had several suggestions to which they were very supportive, and we shall now be putting it in the minutes on the website, which you can see. Give your suggestions to us, and we will definitely take these things forward, so that our college has got this opportunity, and now it is recognized internationally. In the opening ceremony which they had put up the ICA college, the Indian College of Anesthesiologists, with the president and the name of the president, which was a matter of great pride for us, and we should all be proud about it. But we should all strive to work harder. So thank you very much. And now today's webinar, I would invite Dr. Ranju. She's a very, very dynamic director professor in the Lady Hardinge Medical College. You all know her. She's known across India, definitely, and abroad too. And she is very, very senior. She's not very senior, she's a senior. And her areas of interest are obstetric anesthesia, pediatric, life support. And I know that she is involved in all the airway conferences. She was a very, very active co-organizing secretary of our PG Assembly. No wonder it was such a success. She has so many publications and awards to her credit. So Ranju, kindly take over and please start the webinar. Thank you so much.
Thank you so much, ma'am. Very good evening to the listeners. Such a warm introduction, ma'am. I'm very thankful. It's all because of your blessings and sir's blessings. And very happy Diwali to the listeners. The topic today is one of relevance to everyone, whether it is the PGs, it is the private practitioners, or the senior anesthesiologists working in the corporate sector or the government sector. We just can't escape a case of pregnancy-induced hypertension. We have a vast experience being a high referral center for obstetrics at Lady Hardinge Medical College. So the faculty today delivering the talks is one which has a vast experience practically in dealing with the cases of PIH and their subsequent management. We will be taking the webinar in 3 small sections, 3 talks targeted at the spectrum of PIH. Dr. Upma, can we have your screen share, Dr. Upma?
Yes,
Dr. Upma is a professor at Lady Hardinge Medical College. She will be talking about the etiopathogenesis and the clinical features and all the theoretical relevant information that the residents need to go about delivering anesthesia for a patient of PIH. This will be followed by one talk related to the anesthetic management of PIH. And finally, we have a very interesting talk that is related to the use of ultrasound in patients of PIH. That will be done by Dr. Nitin. So can we have your screen share, Dr. Upma?
Yes, ma'am. Just a minute.
Yeah. Dr. Sanish, would you first show us the MCQs before Dr. Upma begins?
Okay.
We have, for the delegates, we have interesting MCQs lined up. We will be discussing the answers to these MCQs at the end of the session. So a brief overview of the subject with the help of these MCQs. Once Dr. Sanish shares these MCQs, I think a couple of seconds can be given on each slide for the delegates to register. And then we can move on. And then Dr. Upma will be doing her presentation on etiopathogenesis and clinical features.
Thank you, Dr. Ranju. We are trying out something like a pre-test question for the academic audience. So here are the questions. There are 4 pre-test questions with single best answers. You can text in your chat box in the live streaming web page. So we'll come to these questions after all the lectures and we'll discuss the answers later on. So here we go. The first question, severe PIH is indicated by all of the following symptoms except option A, pedal edema, option B, intractable right upper quadrant pain, option C, visual scotomas, option D, new onset intractable headache. 4 options. You need to choose the single best option. If you are texting in the chat box, write question number 1 and your choice. Okay, moving to the second question. Magnesium sulfate is indicated in PIH for option A, control of blood pressure in all diagnosed cases of PIH. Option B, prophylaxis and control of seizures in severe PIH. Option C, as an additive to thiopentone if seizures are uncontrolled. And option D, as a routine for seizure prophylaxis in all diagnosed cases of PIH. So you have 4 options. You need to choose the single best response. So you need to write question 2 and your option choice. You can text in the chat box. Moving ahead, third question, the recommended order of drugs used for treatment of blood pressure in PIH without severe symptoms. Option A, intermediate release nifedipine, labetalol, methyl-dopa. Option B, immediate release nifedipine, labetalol, methyl-dopa. Option C, labetalol, intermediate release nifedipine, methyl-dopa. And option D, labetalol, methyl-dopa, intermediate release nifedipine. You need to be very careful while choosing your right answer. Q3 and your option A, B, C, or D. The last question, question number 4, identify the correct statement. Option A, labetalol is the drug of choice for hypertensive emergencies. Option B, general anesthesia should be induced in all patients of severe PIH. Option C, platelet count more than 75,000 per millimeter cube is considered safe for neuraxial anesthesia in PIH. Option D, oliguria is a symptom of severe PIH. You can text in which is the correct option. Q4 space option number. Okay, here are the 4 questions. We'll come to the answers after all the lectures. Back to Dr. Ranju.
Thank you, Dr. Sanish. I hope the students find these questions interesting. The answers to these questions are there in the talks that are going to follow. So here we go, Dr. Upma. The stage is set for your presentation. Please carry on. Thank you so much.
Thank you, ma'am. Good evening, everyone. Everyone. I'll be speaking about etiopathogenesis and clinical features of preeclampsia or PIH as it is commonly called. So how do we, am I audible?
Yeah, but we can't see your screen as yet, Dr. Upma.
You can't see my slides?
No, we can't see them.
Just a minute, ma'am. I have shared the screen. I don't know what is the problem. I'll just end the show and share it again.
Yes.
Yes, ma'am. Now we can see. Yes, ma'am. Yes, slideshow, ma'am.
Good evening, all the seniors and my dear colleagues. So I'll be speaking about preeclampsia.
Can we have the slideshow mode?
Yeah, I have put it. Yeah. Is it okay now?
Yes, ma'am. Yes.
Yes, please carry on.
I'll be speaking about preeclampsia or pregnancy-induced hypertension as it is commonly called. So what is the target BP in the pregnancy? Recently, it has been defined that any BP reading, the target BP in pregnancy should be less than 135 by 85 millimeters of mercury, and any new onset or newly diagnosed blood pressure, systolic blood pressure of more than 140 millimeters of mercury, or a diastolic blood pressure of more than equal to 90 millimeters of mercury, or both, confirmed on 2 occasions, or at least taken 4 hours apart. This confirms the patients to be in the category of having hypertension in the pregnancy by ACOG, or a single BP reading of more than 160 by 110 millimeters of mercury. So there are other hypertensive disorders also present in the pregnancy. If the BP readings are persistently increased and diagnosed before 20 weeks of gestation, then the patient is said to have a chronic hypertension. If the BP readings are newly diagnosed after 20 weeks of gestation, but the patient is not having any maternal or there is no fetal dysfunction, then it is classified to be in the category of gestational hypertension. And if the patient is having maternal and placental dysfunction with the newly diagnosed onset of high BP readings after 20 weeks of gestation, then the patient is put in the category of PIH. Mind it, the line between gestational hypertension and PIH is very thin, and any patient having gestational hypertension can develop PIH subsequently depending upon the maternal or fetal dysfunctions. So what are the diagnostic criteria for PIH? PIH is association of hypertension with proteinuria at least 300 milligram per deciliter in 24 hours of urine, or a urine protein creatinine ratio of more than 30 milligram per millimoles, or albumin creatinine ratio of 8 milligram per millimoles, or both as per the NICE guideline. In case the quantification of protein in 24-hour urine sample is not available, then only dipstick method has to be relied, and a 2+ urine in the dipstick by a dipstick method confers the patient to be having proteinuria. However, in the absence of proteinuria also, the patient can get PIH. Then the criteria are, if the patient is having a low platelet count, that is platelets are less than 1 lakh per millimeter cube, patient is having any renal insufficiency, the serum creatinine is more than 1.1 milligram %, or the serum creatinine doubles the value within week in the absence of any other renal disease, or the patient is having impairment in the liver function characterized by more than twice normal concentration of liver transaminases, or the patient develops pulmonary edema, or there is a new onset headache which is unresponsive to medication and not accounted for by any alternative or relevant diagnosis or patient develops any visual symptoms. There is another category which is known as the severe PIH. Nowadays, there is no mild, moderate PIH, only PIH, severe PIH, and eclampsia terminology is there by the ACOG update. Severe PIH means then the BP reading is more than 160 by 110 millimeters of mercury on 2 occasions, at least 4 hours apart, provided the patient has not been put on any antihypertensive medication by this time, and with the previously mentioned features of maternal and placental diseases, and if it is also associated with persistent right upper quadrant pain, then the patient is categorized in the category of severe PIH. Now, what is eclampsia? When the hypertensive disorder of pregnancy is superimposed by the convulsive manifestation. Patient may have a generalized focal or multifocal tonic-clonic convulsions in the absence of any causative conditions such as migraine, previously known epilepsy, cerebrovascular accident, trauma. These patients, in the almost 80% of the time, the patient will have some premonitory symptoms, but in rest of the cases, patient might not have any premonitory or warning signs, and patient can develop eclampsia even in the antepartum period, during labor, or even the postpartum period also. So this condition is important because the seizures may lead to severe maternal hypoxia, trauma, aspiration pneumonia, and even maternal and fetal mortality. So what is the pathophysiology of PIH? First of all, there is a defective trophoblastic invasion, which leads to improper remodeling of the spiral arteries. In case of a normal pregnancy, the terminal portion of the spiral artery is dilated, and it leads to a widespread and even dispersal of blood flow till the end of the placental unit. We can see that here the time for the blood flow is around 25 to 30 seconds, and the blood flow evenly to the intervillous unit. Whereas in case of preeclampsia or PIH, there is no dilatation of the spiral arteries. The blood flow here is turbulent, and the transit times are high, which leads to impaired oxygen exchange. Also, the presence of persistent smooth muscle cells around the spiral artery in the uterine myometrium leads to incidence of uterine artery vasospasm and persistent placental ischemia. This placental ischemia leads to the cascade of multiple derangements which affect the various maternal end organs and also the fetoplacental unit. Basically, the placental ischemia leads to placental stress, which causes dysfunction of the maternal peripheral endothelial cells. As we know, endothelium is not just a mucous membrane, but it is also an organ which produces a lot of vasogenic mediators. And especially the fenestrated endothelium in the organs such as brain, liver, and glomeruli, they are affected in cases of PIH. There is a systemic inflammatory response activation, and it leads to activation of a coagulation cascade and vasospasm, which leads to a decrease in the blood flow to the various maternal organs. As a result, there are various end organ diseases. The plasma volume becomes contracted because of the vasospasm, and the capillaries become leaky due to endothelial dysfunction. The normal vasodilated state of a normal pregnancy is absent. Although the cardiac output is normal or increased like in a normal pregnancy, but due to vasospasm, there is a hyperdynamic left ventricular function and left ventricular systolic and diastolic dysfunction. Oligemia to the kidneys leads to increased glomerular filtration and further increasing the water and sodium retention. The airway edema is also increased as compared to a normal pregnancy. As a consequence of fetoplacental ischemia, there is a fetal growth restriction, oligohydramnios, placental abruption, non-reassuring fetal status on every examination, consequently leading to an increased risk of spontaneous or indicated preterm delivery. So basically what has happened, there is an imbalance between the vasoconstrictor and vasodilator mediators. There is an increase in the angiogenic markers such as soluble FMS like tyrosine kinase 1 and vasoconstrictors such as thromboxane A2 and endothelins. Whereas the vasodilators such as endothelium-derived growth factor, placental-induced growth factor, prostacyclins, and nitric oxide are reduced. This leads to a generalized state of vasospasm and thrombogenesis. HELP syndrome is one of the special entity of the pregnancy. It needs a special mention because in it there is widespread endothelial dysfunction in the liver cells. There is hepatic necrosis and liver rupture. It is diagnosed by the patient is having, most of the cases patient is having a mild right upper quadrant pain, but it may persist to severe and intractable right upper quadrant pain, which is not explained by any other symptoms. Biochemically, values of LDH are very high to make a diagnosis of HELP syndrome. The LDH may be raised more than 600 international units per liter, and the transaminases are raised. In this case, aspartate aminotransferases are raised more than the alanine aminotransferases. Other features of HELP syndrome are mentioned in its name only, that is the hemolysis, elevated liver enzymes, and low platelet count. Both of these features are previously present in PIH also. So, are there any risk factors which can indicate that the patient is going to develop preeclampsia? Yes, there have been some of the factors have been identified in the recent by the recent research. The strong risk factors that are said to be history of preeclampsia in prior pregnancy, patient having chronic hypertension, maternal BMI of more than 30, pre-gestational diabetes mellitus, patient having antiphospholipid syndrome or systemic lupus erythematosus, and nowadays use of assisted reproductive therapies is being increased because of increased lifestyle changes and increasing incidence of infertility. So these patients are also having, these are the strong risk factors for the development of preeclampsia. There are moderate risk factors also, which include primiparity, changed paternity or primary paternity. Yes, the father is also responsible for the development of PIH in the fetoplacental unit. If the inter-pregnancy interval is more than 5 years or the maternal age is more than equal to 40 years, and family history of preeclampsia, patients who are having multiple gestation or pre-existing chronic kidney disease, these are the moderate risk factors for the development of preeclampsia. Are there any current predictors of PIH? It is under research, but some of the biochemical markers have been postulated to be predictors of PIH. Normally, the concentration of placental growth factor increases during the first 30 weeks of gestation. But in case of preeclampsia, its levels are found to be decreased. And as I had discussed previously, that soluble FMS like tyrosine kinase gets increased in patients who develop preeclampsia. Its levels begin to increase as early as 5 weeks before the onset of preeclampsia, and they remain elevated throughout the pregnancy. So, a soluble FMS like tyrosine and placental growth factor ratio of less than 38 can accurately rule out the likelihood of developing preeclampsia over time. There are some risk prediction models also, like PREDS, which is the prediction model for risks of complications in early onset preeclampsia, or full PIRS, but both of these models are yet not validated. So, can we prevent PIH? Recently, there was a state-of-art review in 2020, and they had commented that only benefit is by giving a low dose aspirin to the patient who have at least one strong high risk factor for the development of PIH, and aspirin should be given in the doses of 75 to 150 milligram once a day, starting from the 12 weeks of gestation until the birth of the baby. And women who have more than 2 moderate risk factors should also be started on aspirin. Other factors that are supposed to be of benefit are the giving calcium tablets to the patient, provided the calcium levels are low. But the factors such as bed rest, fish oil, folic acid, garlic, sodium restrictions, and vitamin C, D, and E have not found to be any use in preventing the preeclampsia. The factors under research are the use of pravastatin, metformin, or exercise. Good diet and exercise as such are going to be vital for carrying a healthy pregnancy in the patient. That's all. Thank you.
Thank you so much, Dr. Upma. That was very comprehensive discussion of all the factors related to PIH. we would now be discussing the anesthetic management of a patient with PIH who comes for a cesarean section. So for that, I'll be sharing my screen. I hope you can see my screen. Right. So is my screen visible, Upma?
Yes, ma'am. Yes.
Right. So we'll be discussing the anesthetic management of a patient with severe PIH. Let's begin with a case discussion, because the talk is targeted at residents who will get this kind of case in the exam. So a 33-year-old woman in her first pregnancy is admitted with a history of normal blood pressure. She has no past medical history of significance. Her BP records during her antenatal visits were normal, but now she's complaining of frontal headache, which is not relieved by analgesics. There's increasing swelling of her ankles, which has reached her mid-calf. And when she comes to the hospital, her blood pressure on admission is 170 by 110. The urine dipstick test done by the obstetrician showed the presence of protein in the urine. A call to the anesthesiologist is sent. As we have seen from the features elicited by Dr. Upma, a diagnosis of severe preeclampsia was made by the obstetricians. They started the patient, as is the practice, on IV labetalol, continued to monitor the patient. And after half an hour, it was seen that the BP was still persistently high. It had not settled down at all, even after starting ibuprofen. And the patient was now complaining of a worsening of her headache and complaining of seeing flashes in front of her eyes. So we've made a diagnosis of preeclampsia, severe preeclampsia. We have put her on labetalol, and the anesthesiologist now is examining the patients. The definitive treatment for this patient is delivery. Once the baby is delivered, only then her situation will improve. And whether or not to deliver the fetus actually is an obstetric decision. It will depend on the gestational age, the maternal and fetal condition, whether she responds to antihypertensive therapy or not. It is primarily an obstetric decision. The anesthesiologist, meanwhile, has certain principles and guidelines to follow, which include control of her blood pressure, evaluation of her intravascular status, as well as her urine output, seizure prophylaxis, the assessment of her airway, evaluation of her coagulation status, and the assessment for end organ damage. The guiding principles of delivery and the management principles are basically going to influence the eventual conduct of anesthesia. Now, severely occurring hypertension with an acute onset that is accurately measured using standard techniques and persisting for more than 15 minutes is called hypertensive emergency. Now, there is enough evidence in literature to indicate that hypertensive emergencies in the mother before the delivery of the baby require treatment. Whatever may the urgency, if you do manage to treat the maternal hypertension, it is known to improve both maternal and fetal outcome. The goal of therapy in these patients is to prevent adverse maternal sequences such as intracranial hypertension, intracranial hemorrhage, myocardial infarction, congestive heart failure, and also help to preserve the placental perfusion. Treatment definitely decreases the risk of maternal death and decreases the risk of a poor fetal outcome. It has also been shown in literature that control of systolic hypertension was more important than the control of diastolic blood pressure in women with PIH who eventually suffered strokes. So it was the systolic hypertension which was directly responsible for the increased incidence of stroke in patients of PIH. Now we've got to know that we need to reduce the blood pressure, but by how much? So the reduction should only be about 15 to 25% in the first 30 minutes to 1 hour, and then it should be lowered subsequently over the next couple of hours. Once you start lowering the blood pressure, This is the target which you need to achieve: a systolic blood pressure of between 140 to 155 and a diastolic blood pressure of 90 to 105. It is important to note when instituting antihypertensive therapy that the fluid status of these patients need to be optimized. As Dr. Upma has outlined, they have a restricted intravascular fluid volume. Therefore, when you start antihypertensive therapy, they can have precipitous fall in blood pressure. The treatment therefore needs to be initiated at much lower dosages because the patient's volume, which is depleted, will increase their risk for hypotension. This is also important because the degree to which the placental blood flow is autoregulated is not very well established. Therefore, with aggressive hypotension, it puts the fetus at risk. Therefore, very low blood pressures should not be achieved with therapy because it will accentuate the fetal distress. One of the commonest drugs which is used for control of blood pressure is IV labetalol. Also, IV hydralazine in literature has been mentioned as a first-line medication, and there is insufficient data in literature to favor one drug over the other. The use of the drug depends upon its availability, the experience of the using anesthesiologist, and the local guidelines of the institute if present. One of the commonly used drugs for control of blood pressure in acute PIH in patients include sublingual oral nifedipine. Now, sublingual nifedipine is not indicated for control of hypertensive emergencies in pregnant patients. It is not approved by FDA or by ACOG. It can lead to precipitous fall in blood pressure, can precipitate cerebral ischemia, infarction, complete heart block, and can also be fatal. In what dose should you use nifedipine? 10 milligrams tablet can be given orally. You can wait for 20 minutes for control of blood pressure. If it does not show any decrease, another dose of 20 milligrams can be repeated after 20 minutes to a maximum of 50 milligrams. This is particularly important in those patients who present with hypertensive crisis in which no IV access is either has been established or will take time to establish. You should always be careful when giving nifedipine because some concern has been raised regarding the additive effects with magnesium sulfate, which these patients are also likely to receive. Now, the drug of choice to reduce maternal blood pressure in hypertensive crisis is IV labetalol. IV labetalol is known to decrease the maternal systemic vascular resistance without increasing the heart rate. It also does not significantly decrease the uterine blood flow. Now, the doses in which you give these drugs is important, and how you titrate them, how you measure the blood pressure is also important. So 20 milligrams IV can be given initially over a period of 2 minutes. Allow 10 minutes for the blood pressure changes to occur. Measure the blood pressure after 10 minutes. If the blood pressure continues to be high, you can give a second dose of labetalol, which is double the previous dose, that is 40 milligrams IV. Again, wait for 10 minutes, then repeat the blood pressure measurement. If the blood pressure fall is not seen, you can escalate the dose and give another 80 milligrams IV over a period of 2 minutes. Blood pressure still does not show a decreasing trend. You can repeat a fourth dose of 80 milligrams IV. So we started with 20 milligrams, doubled to 80, again gave another 80 milligrams, and then another dose of 80 milligrams. However, if the BP by this time has not shown a decreasing trend, it is quite futile to continue with labetalol. Yes, there is a maximum dose which has been mentioned, which is approximately 300 milligrams. But if till now labetalol has not shown a significant decrease in blood pressure, it is unlikely that it will fall any further. And it would be prudent at this time to add a second antihypertensive such as hydralazine delivered IV. Remember that use of labetalol should be done with extreme caution in patients who have a history of asthma or those who have a tendency to develop congestive heart failure. The second drug which can be given for control of blood pressure is hydralazine. It has a potent vasodilating effect. It has a rapid onset and a short duration of action. The initial dose of 5 milligrams can be given over a period of 2 minutes. Now, at least 20 minutes should be allowed for the hydralazine to act. Then you measure the blood pressure. If the blood pressure continues to be high, repeat a double dose of 10 milligrams. Another 20 minutes should be allowed for control of blood pressure. If the blood pressure still does not show a decreasing trend, then a dose of 20 milligrams IV can be administered again. So we started with 5 milligrams. After 20 minutes, you give 10 milligrams. After another 20 minutes, you can give 20 milligrams. And as with labetalol, if still there is no fall in blood pressure, it is futile to continue with the same drug, and it is advisable to add another antihypertensive for control of blood pressure. And now, if labetalol had not been used previously, it can be added as a second antihypertensive. If you see, the dose of labetalol when it is added as a second antihypertensive is double the initial dose of labetalol. When we started with labetalol as a first-line drug, we had used 20 milligrams, but when we use it as a second antihypertensive, it is 40 milligrams. Similarly, if hydralazine is used as a first-line drug, the starting dose is 5 milligrams, but if hydralazine is used as a second-line drug, then the starting dose is 10 milligrams. Remember, hydralazine can produce tachycardia, palpitations, headache, tremors, and nausea, vomiting in the patient. It is very prudent that you give the dose very slowly so that the side effects and precipitous fall of blood pressure does not occur. The other drugs which have been mentioned for the control of blood pressure are usually second-line drugs after the use of labetalol, hydralazine, and nifedipine. These include nitroglycerine, sodium nitroprusside, and esmolol. Now, in many centers who do not have much experience with PIH patients may end up using nitroglycerine or sodium nitroprusside as a first-line drug for control of severe hypertension or hypertensive crisis in patients of PIH. It is not a good drug to start with in these patients. Remember, nitroglycerine is a tocolytic agent. So in these patients, it increases the incidence of cesarean delivery because of the associated tocolysis. It can produce excessive hypotension, and when you use it for a prolonged period in infusion for control of blood pressure, it can lead to methemoglobinemia. Sodium nitroprusside is a cerebral vasodilator. So in these patients who have severe hypertension, it will further increase the ICP and lead to a poorer outcome. It also reduces the venous return. When used in high doses, it undergoes placental transfer and can lead to fetal toxicity in high doses. Esmolol is also known to cross the placenta and can lead to fetal bradycardia in a patient whose fetus is already compromised. So it is not recommended for acute control of severe hypertension in pregnant patients. Now, whether you use labetalol or hydralazine actually depends on the availability, your clinical experience, and institutional protocol if you have any. Whatever drug you use, you should be familiar with its use and its side effects. We had a very interesting study published from our department. This is an international publication which compared labetalol and hydralazine delivered IV for the control of blood pressure in PIH. And one of the results of our study were that when patients come to you with acute hypertensive emergency and they have been receiving labetalol for control of blood pressure in the ANC, IV labetalol should not be given for their control of blood pressure. They've already been receiving labetalol, so now they should be given hydralazine or some other drug for control of blood pressure because they may not respond very well to IV labetalol. You've started the antihypertensives, the patient's blood pressure has started settling down. How frequently should you measure the blood pressure? Your examiner might ask you these questions, so you should be ready with these answers. This is mentioned in the ACOG guidelines that when you have started measurement, you can continue it every 10 minutes for the first 1 hour, every 15 minutes for the next 1 hour, then every 30 minutes for the next hour. And if the blood pressure has begun to settle down, you can measure it every 1 hour for the next 4 hours. Whatever be your method of control of blood pressure, patient's fluid volume has to be optimized simultaneously. Now, you know that the intravascular volume is constricted. You need to give them fluids. How much fluid? About 1 to 2 ml per kg per hour, monitoring the patient's urine output. If the urine output is inadequate, there is oliguria. These patients can be given a fluid challenge with 200 to 500 ml of crystalloid given IV over 20 minutes. If the patient responds with an increase in urine output, the additional fluid may be given as per the patient's requirement. If there is no response to initial fluid bolus, there is oliguria, there is persistent hypertension, this may be an indication for invasive monitoring to be done in these patients. Can you give these patients colloid? They have hypoalbuminemia, they have lower oncotic pressures. Will colloids be beneficial? Yes, they will improve the oncotic pressure, but it ends up increasing the risk of pulmonary edema in these patients. And studies have shown that there is no improvement in outcome when you give colloids versus crystalloids. The recent collective literature indicates that there is insufficient evidence to choose colloids over crystalloids. So keeping in mind their propensity to develop pulmonary edema, it is advisable that these patients be given dextrose-free crystalloids for maintenance of their intravascular volume. The next principle of management is control of seizures. They must be given magnesium sulfate for prevention of recurrent seizures. It's the drug of choice for prophylaxis in severe preeclampsia. It reduces the risk of an eclamptic seizure by more than 50%. The mechanism of action is well given in literature. All the residents listening in must read magnesium sulfate in detail. You can have a short note or a long question on magnesium sulfate by itself. It has very well-defined mechanism of action, which indicates that it blocks intracellular calcium influx, which decreases the vasopressin, decreases the CVR, and helps to decrease the blood pressure in addition. It stimulates the production of prostacyclin by endothelial cells, which aids in the vasodilatation. It is also known to inhibit platelet aggregation, decreases the circulating levels of angiotensin-converting enzymes in patients with severe PIH, and increases the nitric oxide production. There is also some indication that it protects the blood-brain barrier and therefore decreases the cerebral edema formation. The other effects which are important regarding magnesium sulfate are that you must remember it decreases the sensitivity of the motor end plate to acetylcholine, potentiates the effect of muscle relaxants, which you will eventually use in these patients, and also has a mild relaxant effect on the uterine smooth muscle, thereby increasing the uterine blood flow. Fetal effects are important. It crosses the placenta, can decrease the beat-to-beat variability of the fetal heart, and is known in higher dosages to decrease the respiration in the fetus, causes neonatal respiratory depression and hyporeflexia. The regimens are well defined in literature. You can give the IM regimen or the IV regimen. Anesthesiologists usually end up giving magnesium sulfate IV, but you must be aware that the obstetricians are still using the IM regimen, which is 5 grams of magnesium sulfate in each buttock, followed by 5 grams IM every 4 hours in alternate buttock. Now, how you give magnesium sulfate, sometimes your examiner may end up asking this, which is you must check out the magnesium sulfate ampules available at your institution. What is the strength in which they are available? How you will mix them in saline? What is the infusion rate which you will calculate to indicate that, yes, you do know how to make the magnesium sulfate infusion. Now, if the patient has recurrent seizures, once you have started magnesium sulfate in a loading dose and then given it at an infusion of 1 gram per hour, still the patient develops a recurrent seizure or a second seizure, you can give another loading dose and increase the infusion rate to 1.5 to 2 grams per hour. Remember that 9 grams is the total IV dose of magnesium sulfate. This should not be exceeded in the first hour. Now, if the patient still has more seizures after you've given a second bolus dose, you have increased the infusion rate to 1.5 to 2 grams, this is the time when you can go to a second line drug like a benzodiazepine to help control the seizure. Now, how long should you give magnesium sulfate? Now, severe PIH patients undergoing cesarean section should receive magnesium sulfate for at least 2 hours before the procedure, during the surgery, and at least for 24 hours after delivery of the baby or after the last convulsion, whichever is later. There is some literature available now that an abbreviated magnesium sulfate can be given instead of the traditional 24-hour postpartum magnesium sulfate therapy. And it has been shown that this abbreviated magnesium sulfate therapy for 12 hours in patients of severe PIH was associated with less drug exposure, but the outcomes were similar and the benefits were similar as compared to a 24-hour traditional postpartum magnesium sulfate therapy. Now, when given magnesium sulfate, it's important to monitor its level because magnesium toxicity is fairly common. You must monitor the deep tendon reflexes, particularly the patellar reflex, the respiratory rate, the urine output, and the serum concentration. The residents are requested to read up all this and remember at what level, what causes, what reflexes are lost, and at what level of magnesium toxicity begins to occur. Remember, 6 to 8 milliequivalents, a patient will start developing nausea and vomiting. At 5 milliequivalents to 10 milliequivalents, there will be cardiac ECG evidence of toxicity. At 10 to 12, there will be loss of deep tendon reflexes. For those who can't remember this, it's simple to remember 5, 10, 15, and 25. This is the level at which toxicity occurs. Another thing which the examiners can ask you is the conversion of milliequivalents to milligram of magnesium sulfate. 1 milliequivalent per liter is equal to 1.22 milligrams per deciliter. The first warning of toxicity is the loss of patellar reflex. So when should you stop magnesium? If the patellar reflex becomes absent, if the respiratory rate falls less than 10, if the urine output is less than 100 ml in 4 hours, when it has been 24 hours post-delivery, when there is ECG evidence of increase in magnesium levels, or if you are documenting levels and there is documented increased serum levels, it's time to stop the magnesium. Once you have documented magnesium toxicity or you have an absent patellar reflex, immediately stop the infusion. Supportive therapy if there is respiratory depression, and give 10 ml of 10% calcium gluconate for 10 minutes IV. Now, this case, which we had initially seen, remember that patient who had come with hypertension and was given labetalol by the obstetrician. Now we've given her an antihypertensive agent. We've started magnesium. We are monitoring her. She's been put in the left lateral position. And at this time, the obstetricians tell you that there is severe FHR deceleration. And now the decision for cesarean section has been taken by the obstetrician. So what will be your choice of anesthesia and what are your anesthesia concerns? Now, whenever you give anesthesia, whether regional or GA, it's important to have a detailed examination of the patient, which includes history of these patients. Remember, assisted reproduction should be asked for because it is one of the factors which increases the risk of PIH. Any PIH in the previous pregnancy, warning symptoms, any pre-existing hypertension, other comorbidities, family history of PIH, any presence of smoking in the mother, all these are important points to be asked in the history. The pertinent relevant examination that needs to be done is examination of the chest for evidence of any pulmonary edema. Look for the heart sounds and see for any S3 if the patient is in failure. Look for tenderness in the right abdomen and upper abdomen, and then examine the airway. What investigations should you order for this patient who's come for you for a cesarean section? A complete hemogram, coagulation, electrolytes, renal function test, liver function test, including LDH level, a urine analysis, blood grouping cross-matching, a fundoscopy if the time allows, and an ECG. Now, if the patient has to undergo an urgent cesarean section, not much time is available. If you have limited resources, or if urgent cesarean section needs to be done, what are the investigations you should do? One, it's mandatory to do a coagulation profile. These days, a point of care test is available in majority of the theaters where an urgent coagulation profile will give you a result in a couple of minutes and you can know the PT and INR of the patient, and a blood grouping cross-matching needs to be done. The other thing which can be done at the bedside of the patient is the use of a USG to give you relevant information which will help you decide your type of anesthesia. You can use the ultrasound for doing a cardiac ultrasound, for a lung assessment can be done, optic nerve sheath diameter can be evaluated, spine evaluation can be done, gastric volume and airway can be assessed with the help of this ultrasound. Now, once you have done a pre-anesthetic checkup, you need to decide what is your choice of anesthesia. Now, both GA and RA are acceptable, but current literature evidence indicates that regional anesthesia is preferable in patients of severe PIH and is safe. The indications for delivering general anesthesia are extremely limited and they are very well defined. Sustained severe fetal distress or fetal bradycardia, an eclamptic patient with altered mentation and raised ICP, severe ongoing maternal hemorrhage, the presence of severe coagulopathy and patient refusal are the only indications when you should deliver general anesthesia to these patients. The advantages of regional anesthesia are multifold. Avoidance of all the problems that you can encounter with general anesthesia in these patients, avoiding a difficult or a failed intubation, avoiding the risk of pulmonary aspiration, avoiding the problem of a hypertensive response to laryngoscopy, optimizing uteroplacental perfusion. Remember, regional anesthesia has come to stay in all cesarean sections, not only PIH. What is the reason for that? The reason is that the babies are born better. There is improvement in intervillous blood flow when you institute regional anesthesia in these patients. There is a blunting of neuroendocrine stress response to surgery, which happens only when you deliver good regional neuraxial block. Reduction of the incidence of maternal thromboembolism, prevention of neonatal depression. You minimize all the drug interactions which you would eventually use in general anesthesia, and of course, better postoperative pain relief. Now, the dilemma of regional anesthesia was because of the fact that it was thought these patients with the institution of spinal anesthesia will have a precipitous fall in blood pressure. And there was also this dilemma that if you need to treat that blood pressure, it is also associated with problems like a rebound hypertension or the development of pulmonary edema with the fluids that you would give to treat regional anesthesia-induced hypotension. Now, studies have shown that maternal mortality rates related to anesthesia are 16 times greater in patients receiving GA as compared to those receiving regional anesthesia. The slightly lower blood pressure occurring in regional anesthesia pales in comparison to the specter of failed intubation and ventilation and the potential for hypertensive crisis that can occur during intubation and laryngoscopy when general anesthesia is used in severely preeclamptic patients. So we see that regional anesthesia, or should I say neuraxial anesthesia, is much safer. Now, out of neuraxial anesthesia, should you use spinal or should you use epidural? Spinal anesthesia is faster, easier, cheaper. It has a well-defined endpoint, better muscle relaxation, less amount of drug is used. Therefore, it is a better technique as compared to epidural analgesia in these patients. Is spinal anesthesia safe? There was some concern, as I mentioned, of decreased intravascular volume in patients of PIH, leading to catastrophic hypotension. But remember that hypotension that occurs in spinal anesthesia in patients of preeclampsia occurs less frequently, it is less severe, it is very easily treated with small doses of vasopressor. So it has been emphasized both by ASA as well as ACOG guidelines that neuraxial anesthetic techniques, when feasible, are to be preferred as compared to general anesthesia for severely preeclamptic or eclamptic patients. However, the regional anesthesia or spinal anesthesia should be given by a skilled anesthesiologist. Preferably, a single shot should be given and with the use of a thin needle. Now, there are special considerations when you give regional anesthesia. We'll be dealing with each one of them. The most important is the coagulation status of these patients. When the platelet count is more than 1 lakh, it is absolutely safe to give regional anesthesia, spinal anesthesia. When the platelet count is less than 50,000, then the neuraxial block is contraindicated. It is between this 50,000, that 70,000, between 50 to 70,000, that it is a gray zone. and clinical indications should decide whether it is safe to give regional anesthesia to these patients. Every time you decide to give regional anesthesia, remember that coagulation profile needs to be done. APTT, PT, and INR should be done. If available, a TEG and ROTEM will also indicate the coagulation status in these patients. This can be done as point of care tests. How frequently should you do these tests? If the platelet counts are stable, the last platelet count can be available, if available, about 6 hours prior to the surgery is acceptable. If the count is decreasing, then the platelet count should be done at least 3 hours before instituting the neuraxial block. When you give the spinal anesthesia, use a lower concentration of local anesthetics along with additives. The purpose of using a lower concentration of local anesthetic is to decrease the duration as well as the severity of motor block. When you have less motor block, you will be able to monitor the patient more effectively in the postoperative period for developing epidural hematoma. Remember, if you give these patients epidural anesthesia and put in a catheter, the platelet count must be checked before removing the catheter as well. Now, another question which is important is, does a preoperative platelet infusion help? If the platelet counts are low, you want to give regional anesthesia like a spinal anesthetic. Can you give them a platelet infusion and then give them a block? What are you really scared of with thrombocytopenia? You're scared of a spinal hematoma. And there has been a consensus guideline recently issued in 2023 regarding this topic of neuraxial procedures in the context of thrombocytopenia. Now, you are basically looking for a spinal hematoma, the instance of which in obstetric patients, even with thrombocytopenia, is relatively rare. How does it present? It presents with lower motor deficit, back pain, lower extremities, paresthesia, occasionally urinary and bowel function. 95% of the patients will present within 48 hours of giving the spinal anesthesia. And if you do detect it, you need to have an urgent neurosurgical consult and a decompressive laminectomy done within 48 hours of symptom onset. Otherwise, the prognosis will be very poor. So should you give these platelets, patients platelets and then proceed with spinal anesthesia? As per the ACOG think tank, yes, you can give them if the platelet count is less than 50,000, particularly if there is a life-threatening hemorrhage that the patient is having and in preparation for urgent surgery. Now, these are obstetric indications which have been outlined. As per the ASTRA guidelines and the American Society of Hematology, they have indicated that preeclampsia is a consumptive coagulopathy. So transfused platelets are rapidly consumed and the threshold levels which are safe for giving a spinal anesthesia may not be reached. In addition, there may be associated risks of transfusion reaction, circulatory overload, and TRALI. So you should be very careful in giving regional anesthesia to patients who have an established thrombocytopenia in PIH. Now, you must also understand what fluids to give when you are giving these patients regional anesthesia. Isotonic non-glucose containing solutions at the rate of 10 ml per kg can be given. And the need for preloading is less when you give a lower concentration of local anesthetics with opioids. The volume of preload is higher and intraoperative fluid consumption is in fact higher with non-preeclamptic patients as compared to preeclamptic parturients. So you do need to give them fluids, but the amount of fluid required is less. Another point which needs to be considered is if hypotension occurs, should you treat it and how should you treat? Yes, they will have hypotension, but as we said, it is transient and easily treatable. Small amounts of phenylephrine, like 25 to 50 micrograms, can be given for treatment of hypotension. Remember, do not give a large dose and titrate to effect. So start low and go slow. With careful dosing, greater sensitivity to vasopressors is not a clinical problem in these patients. Can epinephrine be used in labor analgesia in these patients, or can it be used for anesthesia in these patients? It is preferable that you avoid the use of epinephrine with local anesthetics. It is not really required in routine administration of labor analgesics also because it has only a modest local anesthetic sparing effect. Now, let's go back to the case. We had started an antihypertensive. The BP had started to stabilize. Urine output was adequate. Blood tests, which was sent earlier, have now come and show a low platelet count of 50,000, 55,000. This patient definitely needs general anesthesia, and regional anesthesia is contraindicated. If this patient, while managing, has a GTCS, she has thrown a seizure while you're giving her antihypertensives and magnesium sulfate, and then she needs to be taken for a cesarean. Meanwhile, she throws a seizure. What will you do? Will you give her general anesthesia? And what will be your concerns in anesthesia in this patient? Remember, there is a term known as stable eclampsia. The concern of giving regional anesthesia to a patient with eclampsia is one, the possibility of coning or when the ICP is raised in these patients and you give a lumbar puncture, and the possibility of convulsion during the procedure. But there is a small category of patients whom we know as stable eclamptics. These are patients who are conscious and cooperative, who've had no convulsive episode for the past couple of hours. You find no evidence of raised ICP on fundus examination. There is no, if a patient is conscious and cooperative and responding well, that's the best clinical indication that she has no signs of raised ICP. If you've started her on antihypertensive and magnesium sulfate, her urine output is adequate, her coagulopathy is not there, she has no systemic complications like congestive heart failure, she is termed as a stable eclamptic and can be given a spinal anesthesia. We have a beautiful paper from the department. This is an international publication where we have given spinal anesthesia to stable eclamptics and found that it avoids the risk of general anesthesia, is safe, and does not cause any major complications. Now, the problems with general anesthesia in these patients are multifold. Difficulty in securing the airway, effect of magnesium sulfate on neuromuscular transmission, increased risk of PPH, need for postoperative intensive care, adverse risks for the fetal outcome, but most importantly, the hypertensive response to laryngoscopy and intubation, which can actually be the most important red flag when you give general anesthesia to these patients. These patients can have a difficult airway, but what exactly in the airway is difficult, that you must know. These patients can have laryngopharyngeal edema, they can have tongue swelling, they can have cochlear engorgements, which means that the internal diameter of the trachea is less, which means a smaller endotracheal tube. They can have a friable mucosa with an increased tendency to bleed. They can have weight gain, increased neck circumference, large breasts, which means that laryngoscopy can be difficult. And the subglottic edema, which they develop, means that they can develop postoperative airway obstruction. So the airway is difficult, and what this translates clinically for you means that an experienced person should be delivering anesthesia to these patients and should be managing their airway. You should have ready a small size endotracheal tube, a variety of laryngoscope blades. The presence of a video laryngoscope really helps. Keep a supraglottic device ready. Keep fiber optic and surgical airway equipment ready in case you run into trouble. Avoid repeated attempts at laryngoscopy and intubation. Remember that, as I said, preventing the pressor response to laryngoscopy is of the utmost importance. Hemorrhagic stroke as a result of the precipitous rise in blood pressure is the most important cause of mortality in patients with 3 eclampsia. You must prevent the rise in mean arterial pressure above 110 millimeters of mercury. There's a whole list of drugs which you can use for control of blood pressure, and this you must know. The other problem in giving general anesthesia in these patients is prolonged neuromuscular blockade as a result of use of magnesium sulfate, which blocks the calcium channels at the motor end plate. Remember that it potentiates all aspects of neuromuscular blockade. The speed of onset is increased, the duration of block is prolonged, and it is recommended that if the patients are receiving magnesium sulfate and you do give them general anesthesia, you monitor the neuromuscular junction. The monitoring of these patients undergoing anesthesia is the standard, but you must also monitor the magnesium levels and the coagulation profile. What is the role of invasive monitoring? It is very limited. It is not unique to patients of PIH. The same indications as for CVP in any other patients are valid. But with the onset and availability of non-invasive monitoring for cardiac output, invasive monitoring has less of a role. The PCWP is indicated in these patients if there is intractable hypertension, presence of pulmonary edema, and oliguria that is unresponsive to fluid therapy. Utrotonics, you can give oxytocin in small dosages. Ergometrine is definitely to be avoided. When you give these patients anesthesia and they have a convulsion, what should you do? The basic measures of control of airway, preventing aspiration, supporting breathing and circulation, and magnesium sulfate boluses can be given. If you're giving an infusion, its rate can be increased. If the patient still has persistent convulsions, even after giving second bolus and increasing the infusion of magnesium sulfate, it is then when you end up giving benzodiazepine or probably thiopentone. They are not recommended as an alternative to magnesium sulfate in eclamptic seizures. If these patients have a delayed recovery, what are the causes? The causes can be the same as any other patient who has delayed recovery. But you must remember, if your patient is not waking up after general anesthesia, do suspect an intracranial event that has occurred, which can range from a cerebral edema to ongoing seizures to the development of intracranial hemorrhage and PRES. Now, which of these patients should be shifted to the ICU? Any end organ damage or any intraoperative complication that has occurred means you must shift the patient to the ICU. The presence of pulmonary edema, congestive heart failure, DIC, HELP syndrome, severe oliguria, the presence of postpartum hemorrhage in these patients are all indications that these patients should be shifted to the ICU. What postpartum care should you give? Continue the monitoring which you have instituted intraoperatively, provide adequate analgesia, make sure the patient is nursed in a comfortable and quiet position. Neuraxial morphine or clonidine can be added to the spinal anesthesia to ensure good pain relief. And in the presence of coagulopathy, you can give these patients acetaminophen and systemic opioids. The use of NSAIDs should be instituted only when there is no coagulopathy. Peripheral nerve blocks under ultrasound guidance like TAP block and QL block can also be given for anesthesia. Remember, QL block is a deep-seated block and should not be given in the presence of documented coagulopathy. Maintain strict input-output charting. Remember, the risk of preeclampsia continues to be there in the postoperative period because of the high IV fluids that end up being given intraoperatively and the risk of autotransfusion causing hypertension stays in the postoperative period. Continue magnesium sulfate, continue antihypertensive, and these patients are at a high risk of developing pulmonary embolism. So prophylaxis for them can also be instituted in the postpartum period. We have two more beautiful papers from the department regarding PIH. Interested people may have a look at these. This is spectrum of neurological complications in patients with eclampsia from our hospital and the presence of atypical presentation of PRES in our patients. Is there any role just to summate the talk, your examiner might also ask you the role of labor analgesia in PIH. This is the same as the role of labor analgesia in any patient, where it blocks the sympathetic response and provides hemodynamic stability, improves intervillous blood flow. So this is the suggested readings, and thank you for a very patient listening. Thank you so much. Dr. Sanish, can we have Dr. Nitin's presentation, please? Because yes, Dr. Nitin, Nitin's presentation is with Dr. Sanish. Can we now have the presentation on POCUS and its role in patients of PIH? POCUS ultrasound is now a tool which is available with all anesthesiologists. It has multiple uses in patients of PIH in the preoperative examination, intraoperative management, and postoperative care. So this talk by Dr. Nitin Hayaran, who's a professor of anesthesia at Lady Hardinge Medical College, with a vast repertoire of experience in dealing with PIH patients, is the next part of the webinar. So can we have his presentation, Dr. Sanish?
Yes, ma'am. Rituparna is sharing the screen.
Yes, thank you so much.
Good evening, everybody. At the outset, I would like to thank ICA and Dr. Ranju for inviting me for this talk. So, I think you all have discussed about the basic of pathophysiology and clinical manifestation of pregnancy-induced hypertension as well as its perioperative management. I'll be discussing briefly the basics of application of POCUS in pregnancy-induced hypertension. So the learning objective will be to understand the application of POCUS in PIH patients for assessing the maternal cardiovascular status, pulmonary status, as well as the cerebral status in terms of cerebral edema. So we'll start with a case, and that is most commonly usually we see whenever we are in an ICU. So this was a 36-year-old housewife admitted to the gynae casualty with complaints of shortness of breath. Patient complained of headache but was calm. Clinical examination revealed an increase of BP of 162 by 100 with tachypnea with a low saturation of 95 to 96% on room air. On auscultation, patient had fine cleft present. At this point of time, it is actually very difficult to find to say whether these clefts are because of the capillary permeability or because of the cardiac dysfunction because of the severe increase in the BP. So then the patient was managed with oxygen at the rate of 4 liters per minute with face mask, labetalol, 20 plus 20 for identification of the urinary status, the urine output. The urethra was catheterized and patient was found to be oliguria. Now, whether to, again, second dilemma is whether to give fluid, how much fluid to give, whether the fluid has been given adequately. It's very difficult to assess by the clinical examination alone. And then the cerebral, if the patient is having headache or is irritable, if the patient is having raised IP, especially when we are planning for the delivery of the baby with the help of neuraxial anesthesia. So I think pathophysiology, it has already been discussed. So it has endothelial dysfunction with capillary permeability, vasospasm, altered hemodynamic, leads to increase in the left ventricular dysfunction. Complications to monitor are pulmonary edema, cardiac dysfunction, and cerebral edema. So POCUS helps in PIH. So POCUS is a point of care ultrasound. It is a quick, non-invasive bedside test usually performed by the clinician providing the care, or to the location where the patient is receiving its care. So how when we say the use of POCUS in maternal cardiac assessment, it helps in qualitative or quantitative assessment of the left ventricular function. When we say about pulmonary evaluation, it helps, the lung USG helps in detecting the interstitial syndrome, frank pulmonary edema. ONST helps in detection of the cerebral edema or raised interstitial. So, so our normal USG machines with can be utilized for this POCUS. Various probes depending on the examination that has been planned can be used. So, like linear probe can be used for apical lung scanning, pulmonary scanning, as well as for ONST. Phased array is most commonly used for the lung scan as well as the cardiac scanning, and the curvilinear is usually for the lung scanning and abdominal scanning. Most in a patient, all the three probes may be used, or only a single probe can be used. So we'll begin with the cardiac POCUS. So cardiac focus techniques usually encompasses the various views of the heart to visualize the left ventricle and the right ventricle, right atrium, and to assess their function. The pericardium and the outflow tracts. The most common is the parasternal long axis, followed by parasternal short axis. And subcostal view basically is utilized for the visualization of all the 4 chambers as well as the IVC. Apical 4 chamber is also utilized for the viewing visualization of all the 4 chambers of the heart. Starting with the parasternal long axis. So usually a phased array probe is kept in the 4th or the 5th intercostal. It's just lateral to the sternum, with the pointer pointing towards the right shoulder. So here we see the heart, the left ventricle along its long axis. So you can see, identify the right ventricle at the top, left ventricle, left atrium, left ventricular inflow tract, and this is the aorta and aortic valve, that is the left ventricular outflow. So these are the things that you can visualize in the parasternal long axis view. In the same location, now the probe is rotated so that the pointer is pointing towards the left shoulder, and you see the left ventricle in its circular fashion with the right ventricle over the left ventricle. You see the papillary muscles, the left ventricle, the mitral valve can be visualized in fish mouth through the, depending on the intercostal space we are viewing through. Then is the parastern, the apical 4th chamber, usually done for when you want to see the left ventricle and right ventricular together to see their interaction. So the probe with the marker to the left side of the patient, kept around at the 5th or 6th, just below the nipple, and you identify the left ventricle, right ventricle, left atrium, right atrium. Subcostal or subxiphoid view is just at the subxiphoid area with the marker on the left side. Now we are seeing through the liver. So identify the liver, right ventricle, left ventricle, right atrium, and the left atrium. Here, especially in the antenatal period, it is difficult to visualize because of the gravity. Commonly done in the postpartum. So now, whenever this type of patient, like our patient who comes with dyspnea, and we want to assess the cardiac, so there are, so we can do by qualitative assessment, we can do by quantitative assessment. So you know that, especially the patient, if you present in the with the early onset PIH have systolic dysfunction, and the late onset PIH have diastolic dysfunction. So if there is no systolic dysfunction, most probably it is because of diastolic. But qualitative assessment can be done only for the systolic dysfunction. So let's start with the qualitative assessment of ventricular function. So first is the myocardial excursion, myocardial short, and mitral valve excursion, that is anterior mitral valve leaflet excursion. Which views can be used? Any view. It can be by apical, subcostal, long axis, short axis, parasternal long axis, short axis. But we prefer mostly parasternal long axis and short axis in the pregnant patient. So what is myocardial excursion? You just put the probe in the parasternal long axis and see whether the ventricles are the walls squeezing in systole. If they are squeezing, it is a normal excursion. Now in this, you can see there is no excursion of the ventricle, the septal, and the prelateral wall. So there is no excursion, that is, the myocardial excursion is poor. So it can be quantified with the help of fractional shortening, but I'm not going into the detail. Then myocardial shortening. Usually we do in the short axis. Are the walls getting thicker during this systole? So if you see in this, so the walls are getting uh, thicken at this systole, and here you were not able to see the walls getting thickened during this systole, especially at the septal free wall. So observe the cardiac muscles in a similar fashion as the spinational long axis, and ensure all the walls are moving inwards equally. So now see the mitral wall excursions. See this mitral wall anterior leaflet moving toward the septum. Moving toward the septum. So closer, better is the left ventricular function. Oh.
Dr. Ritupatla, has the presentation ended?
I think it got terminated in between, no?
But
It
there is no
hadn't.
sound. There was no sound coming further. Hello?
Can you start the presentation again and bring it to the same point?
Okay, just a minute, sir. I'm trying again. Thank you.
Yeah, we had done this, yeah. Yes.
So when we scan at any of this thing, we can appreciate the normal thing, that is the A lines. So this is the pleural line, and followed by the reverberation or artifact of the normal pleura. We see multiple A lines below the pleural line. This is normal artifacts. Then comes the B lines. So B lines basically are comet-like signals rising from the pleural line, and which have a to and fro movement because of the lung sliding. They synchronize with the respiration, and they present reverberation artifact through edematous interlobular septa or alveoli. So they just tell about the increase in extravascular lung water diagnosed by multiple B lines or comet tails. More than 3 are considered significant. So now differentiating between the interstitial lung edema and alveolar. So if there are multiple lines which are more than 7 mm apart, they are basically because of interstitial edema, and there are multiple lines which coalesce together, like less than 3 mm or apart. They are because of the alveolar edema. So idea is to have the integration of both these scans. To integrate the pulmonary scan with the cardiac focus. To start with the pulmonary scan, assess whether there are B lines present. Then if there are B lines present, go for the left ventricular assessment for left-sided heart pressures as well as ejection fraction, and then you make a diagnosis of either it is because of cardiogenic or with the air. You can follow any of the protocols for the fluid responsiveness and the scans. Then comes the assessment of the cerebral edema, that is by the optic nerve sheath diameter. It is an indirect marker of elevated ICP in patient with eclampsia and severe preeclampsia. So optic nerve sheath is a sheath enclosing the optic nerve, and it is directly continuous with the dura mater and the CSF. And the optic nerve sheath is sensible that it reflects the pressure of the intracranial pressure. So CSF pressure variations influence volume of the optic nerve sheath diameter. So what we do, it is most commonly distensible at around 3 mm below the optic disc. So 3 mm behind the globe, one is the measurement 3 mm posterior to the globe in both the eyes. Normal it is around 4.3 to 4.8 mm, and raised when it is more than 5 to 5.5 mm. So measurement technique is straightforward. Patient is lying supine with eye covered with tiger down. High frequency linear probe is utilized. Minimum pressure is applied on the eyeball, and there is use an ample amount of gel as a conducting medium. And you measure the optic nerve sheath diameter in both coronal as well as the sagittal. So this advanced POCUS can enhance the management of PIH by providing real-time information on maternal and fetal. So encourage the incorporation of POCUS into routine obstetric and care. Thank you.
Thank you so much, Dr. Nitin. That ends the third presentation. I would also like to add to this that besides the wonderful lung and cardiac scans, which Dr. Nitin has talked about, we can also use the ultrasound for a quick gastric volume assessment and also evaluation of the spine. So in those cases where there is a dilemma of whether to give this patient spinal anesthesia, whether to give this patient general anesthesia, a quick assessment of the optic nerve sheath diameter will tell us whether the ICP is raised or not. A quick assessment of the gastric ultrasound will tell us whether she's full stomach or not. And we can have an assessment of her volume status also with evaluation of her IVC distensibility. All these uses of ultrasound by the bedside have really revolutionized the management of anesthesia in patients of PIH, making it much more evidence-based as well as safe. So that concludes all the three presentations. It's open for discussion. Dr. Nitin is also present now. So if there are any questions, we'll be happy to answer that. And good evening, Baljit sir.
Very good
Ma'am,
evening.
we have to take.
Enjoyed all the talks. Excellent.
Ma'am, pre-test question answers.
Yes. So can we have the questions displayed again, please?
Do you have the questions? Sanish sir has lost. Sanish sir has left.
Okay. I have the questions. Give me a minute.
Yes,
yeah.
ma'am.
And I can share this. You'll have to allow me to share my screen again.
Yes, ma'am.
Yeah. Right. Visible?
Yes, ma'am.
So this was the first question we had asked. Severe PIH is indicated by all the following symptoms except. So the answer for this is A, pedal edema is not part of the diagnostic features of severe PIH. PIH can occur without the occurrence of pedal edema, or mild edema may be present in all patients at term who do not suffer from PIH. So the answer for this question is A. The second question was magnesium sulfate is indicated in PIH for what all conditions? The answer to this is B. It's used for the prophylaxis and control of seizures in severe PIH. It is not used in all cases of PIH. It's used only in those cases which have severe PIH for prophylaxis and control. So the answer to this is B. Question 3, the recommended order of drugs for treatment of blood pressure in PIH without severe symptoms. The answer to this is C. So usually it is labetalol followed by nifedipine, and if required, then methyl-dopa. So this is without severe symptoms. Question 4, identify the correct statement. The answer to this is A. Labetalol is the drug of choice for hypertensive emergencies. So that concludes all the MCQs which we had shared. Thank you. It's open for discussion in case there are any questions.
Yes, ma'am. We have questions. One is question is any role of dexmedetomidine? This question has been asked by Dr. Naresh Paliwal.
Dexmedetomidine has been in what form? Does he want to know, Naresh sir, as an additive to the neuraxial blocks or as a sedative in these patients?
Not specified.
Okay, so yes, it can be used in patients for mild sedation, but PIH patients whom we give regional anesthesia, we really don't feel like putting them to sleep too much. We need them to be awake so that we can monitor these patients better for any intracranial problem. We need them to be awake at the end of surgery to enhance maternal bonding with the baby. And so as a sedative in PIH with regional anesthesia, the role is really limited. And in case you want to give regional anesthesia as an additive to spinal anesthetic, yes, it may have a limited role. I have more experience with clonidine. We have done a couple of studies with clonidine as an additive to spinal anesthesia. The fall in blood pressure becomes slightly more pronounced. So with dexmedetomidine, I have limited experience, and I would feel that in patients who have unmonitored cardiac status, you don't know whether they have cardiomyopathy or not, you don't know, you've not evaluated the cardiac status, to use a drug like dexmedetomidine with spinal anesthesia is a little risky. So we would stay away from using dexmed in these patients. I still prefer to use morphine for analgesia. I add it to the spinal anesthetic in these patients. And I have used small amounts of clonidine. But with dexmed, I have limited experience.
And ma'am, next question is by Dr. Dharmalingam. Any comments about circulatory overload by platelet infusion?
See, platelet infusion we had talked about in the context of correcting the thrombocytopenia. If you want to give a regional anesthetic, if it is so indicated, for example, it's a very difficult airway, she's full stomach, there are other problems, and you want to give regional anesthesia, then you may end up giving more platelets to these patients. In that case, if you do not take into account the other fluids, you give them some amount of preload, you've also started them on magnesium infusions, you know that if you don't take care of that fluid which you are simultaneously giving to these patients, then even a little amount of extra fluid can just shift them over the edge. So we should be cognizant of the fact that everything adds to the fluid volume, whatever is delivered in the intravascular space. So in that context, when you're rapidly giving platelets to build the platelet count, you must be careful that it can add to the circulatory one.
Ma'am, may I add to the dexmed comment?
Yes, please.
Actually, in India, as such as FDA hasn't recommended dexmed for intrathecal use, and so whatever use we have been reading in literature is actually the off-label use.
Yes. No, I know Naresh sir has a lot of experience in using dexmed for his segmental spinal patients.
Yes.
But for patients of PIH who do not have a cardiac evaluation, who are not ASA grade 1 or 2, we don't know if they have any cardiomyopathy or not. Using it in these patients, I would be a little wary.
And we can always have POCUS now, as we have taught, and
yes,
then
yes, we do.
still.
But see, using dexmed in the intrathecal space, even if you've done a POCUS, you can't undo what has gone in. So and then if they have, I know that I have used clonidine. I know that in small dosages, it does not produce significant hypertension. But maybe DexMed in the next couple of years will have an emerging role. Definitely non-pregnant patients, we have used extensively. It provides beautiful long duration analgesia without any significant side effects. In appropriate doses, there's hardly any bradycardia, there's no hypertension, all the problems of opioids do not occur. So, but in pregnant patients, especially with PIH, I would be a little wary.
Yes, ma'am. That's it. No more questions, ma'am, in the chat room. Some people have answered the questions. Yes. So that's it, ma'am. We can conclude. We can.
Right. Anything, Baljit sir, Jayashree ma'am, Dr. Radhakrishnan sir?
After such an excellent discussion by the stalwarts, I don't have anything much to tell the students.
Baljit sir?
Except, of course, the webinar was excellent. The only thing I can say is that this questions that we have started is a very good gesture. And I think the students will also really look forward to that. So I think, yeah, Baljit is there.
Yes, ma'am.
Yes, ma'am.
Radhakrishnan
I
sir
think,
is also there.
excellent presentations, all three of them, and Dr. Ranju had done a great, I would job with her anesthetic management. There were a lot of things I think which the postgraduate students can learn from this particular talk, and other talks as well by Dr. Upma as well was very good. In fact, all three were excellent talks. My compliments to all the three speakers.
Thank you, sir.
Thank you, sir. Thank you, sir.
Dr. Radhakrishnan sir?
Sir, you are muted. Radhakrishnan sir,
Muted,
you
sir,
are muted.
muted. Sir, you're muted.
Mhm. Yes, mhm. Radhakrishnan sir, can you hear us? You are muted.
No, sir's muted, so.
Yes.
Dr. Radhakrishnan, you are muted. Kindly unmute yourself. Yeah.
Yeah. Thank you.
Yes.
Thank you. Could I be heard?
Yes, sir. Now.
Yes, sir.
Yes. Now
Yeah.
you're on.
Thank you, Ranju, for the excellent show. Excellent. Good. Good.
Thank you.
And we are thankful to you, Upma and Nitin.
Thank you, sir.
Thank you, sir.
Yeah. For
So we
helping
can-
us with this particular webinar.
Right, sir. So we
And
can.
it was dealt in detail. I must say it was dealt in detail than we usually have the discussion on pregnancy-induced hypertension. We are thankful to you. And Baljit, could you wind up?
Yes, sir.
Yeah, I think Dr. Jayashree Sood has already expressed thanks. It's already done. But once again, I can say on behalf of Indian College of Anesthesiologists, we thank all the speakers, the moderator in particular, for not only moderating the session so beautifully, for an excellent talk that she has delivered. And a few questions which were there were very, scientifically answered as well. And I'm sure whoever have asked these questions, they'll be satisfied with that. So with this, if there is nothing else, no more question now. So I think we can wind it up. It's a festival time, and
Yes.
wish you all the very best on behalf of Indian College, all the people who are attending this, as well as the speakers and the moderator and everyone who has participated in this webinar. A very, very happy Diwali, and wish you all the very best during the forthcoming festival. Thank you so much,
Thank
and
you.
good night.
Wishing everyone a very
Thank
happy
you.
Diwali.
Thank you. Happy
Good, good.
Diwali.
Thank you.
Good
Wish you all
night.
happy
Good night,
Diwali.
ma'am.
Thank you, sir.
And good
Good
night.
night.
Good night.
Good night, Dr. Upma. Good night, Ranju ma'am.
Thank you. Good night.
Night.
Mhm.
Thanks to Ms. Rituparna. I'm sorry I forget all the time for providing the digital platform. Thanks, Ms. Rituparna, on behalf of ClearNet.
Thank you.
You can
Thank you, sir.
You can stop recording, Ritu, and good night to you.
Yes, sir. Thank you so much, and wish you all a happy Diwali.
Thank you. Thank you.
Thank you. Goodbye, sir. Take care. So with all your permission, we are signing off now.
Yeah.